Bismillahirrahmanirrahim. So last time we were discussing about the nuclei of the thalamus, and the last thing that we discussed was that the pineal gland is called as the epithalamus. Moving forward, there is the Uworld point about thalamic stroke. So complete contralateral pure sensory loss. For example, touch, pain, temperature, vibration, and proprioception. Severe proprioceptive defects may cause unsteady gait. So in thalamic stroke, suppose there is stroke in the thalamic area or in the artery that was supplying the thalamus, there will be complete contralateral, that is of the opposite side of the body, pure sensory loss, because almost all of the sensations before going towards the cortex relay into the thalamus, and if there is any stroke to the thalamus, there will be a pure sensory loss of the contralateral side of the body. Then thalamic syndrome. Neuropathic syndrome due to thalamic lesion occurs in 10% of the stroke patients, usually a lacunar stroke in the thalamus. Contralateral sensory loss will be seen in the face, arms, and legs, and all sensory modalities, including the touch, pain, temperature, vibration, proprioception, everything will be gone. Resolution can lead to long-term chronic pain. Initial paresthesia is followed in weeks to months by allodynia, that is, ordinarily painless stimuli cause severe pain, and dysesthesia, that is, unpleasant, abnormal sense of touch, and that is happening on the contralateral side. Sensory exam will be normal, and severe pain in paroxysm or exacerbated by touch. The next point is about hypothalamus. So hypothalamus maintains the homeostasis by regulating the thirst and water balance, controlling the adenohypophysis, that is anterior pituitary, and neurohypophysis, that is posterior pituitary, release of the hormone produced in the hypothalamus. So regulating hunger, autonomic nervous system, temperature, and sexual urges, which mean 10 hats. So thirst, adenohypophysis, which is the anterior pituitary. So hypothalamus will release the most of the releasing hormones and some inhibitory hormones like dopamine on the anterior pituitary to regulate the release of hormones from the anterior pituitary. And for the neurohypophysis or the posterior pituitary is not a gland in itself. It is just a docking station from which the hormones which are already produced in the hypothalamus, which are oxytocin and ADH, will come and will be released. They are not produced in the posterior pituitary. Nothing is produced in the posterior pituitary. Hormones are produced in hypothalamus. They come to the posterior pituitary just to be released into the blood. Then we have the regulation of hunger, autonomic nervous system, temperature, and sexual urge. So you may remember the mnemonic 10 heads for the functions of hypothalamus. Inputs. Inputs to the hypothalamus are from the areas which are not protected by the blood-brain barrier. OVLT senses a change in osmolarity, and area postrema, which is found in the medulla, responds to the emetics. Emetics are the substances which may cause vomiting. Then we have the lateral nucleus. The lateral nucleus of hypothalamus is responsible for hunger, and ventromedial nucleus is responsible for satiety. You must remember these two very well because they are high yield. So the lateral nucleus, which is responsible for hunger, destruction will lead to anorexia, failure to thrive in infants. It is stimulated by ghrelin and inhibited by leptin. So, okay, a lateral injury makes you lean. If you have an injury in the lateral nucleus, you will not feel hunger, and if you are not feeling hungry, so you will not eat, and that is how you become lean. Ventromedial nucleus is responsible for satiety. Destruction, for example, in the case of craniopharyngioma, will lead to hyperphagia, that the person will eat a lot, and that is stimulated by leptin. Ventromedial nucleus injury makes you very massive. So you may remember this mnemonic, it is a very good one. So the thing that I want to tell you is that there is a hormone that is called as leptin. Leptin is produced from the adipocytes. If you are eating a lot, there are a lot of adipocytes which are formed in the body, and those adipocytes are releasing leptins, and that leptin is stimulating the satiety center to tell your brain that you have eaten enough. But in the case of yes, leptin stimulates the ventromedial nucleus, but it inhibits the lateral nucleus of the hypothalamus, that is a hunger center. So basically, the hunger is decreased and the satiety is increased by the hormone leptin, and reverse is true for ghrelin. Sorry, the anterior nucleus of hypothalamus is responsible for cooling. Parasympathetic vasodilates to cool. Anterior nucleus cool off. Cooling and parasympathetic effects are, AC, air conditioners are present in your homes. So anterior nucleus is responsible for cooling, and anterior nucleus is also responsible for the parasympathetic nervous system. The posterior nucleus is responsible for heating. How does it do that? It stimulates the sympathetic nervous system, and sympathetic nervous system causes vasoconstriction. Suppose this is the skin, and on below the skin we have a blood vessel. If that blood vessel, I'm sorry, suppose this is a blood vessel. If this blood vessel is constricted, like suppose this blood vessel is constricted, so if there is a constriction of the blood vessel, the heat will not be dissipated outside. Thus, basically filtration will not occur, sweating will not occur. So because of the vasoconstriction, heat from the capillaries will not be dissipated, and heat will be retained inside the body. That will rise the temperature of your body. But if there is vasodilation of this blood vessel, so there will be increased chance of substances to be filtered out into the interstitial space, and increased amount of sweating will be there. Along with that, there will be increased conduction of the heat, and that will liberate the heat out of the body. So you must remember these 2 points. Next is over here, heating controlled by the posterior hypothalamus, that is hot pot. So hot pot hypothalamus posterior is responsible for heating. If you zap your posterior hypothalamus, you become a poikilotherm, that is cold blooded like a snake. You know that the snakes, they cannot adjust the body temperature according to the environment, so their internal body temperature becomes equal to the external environmental temperatures. That is why they are called as poikilotherms. And if we have a damage to the posterior nucleus of our hypothalamus, we will also become poikilotherms. Then suprachiasmatic nucleus is responsible for regulation of the circadian rhythm. You need sleep to be charismatic, that is chiasmatic, and you also need sleep to score well in the step 1 exam. Then we have supraoptic and paraventricular nuclei. They synthesize the ADH and oxytocin. ADH and oxytocin are carried by the neurohypophyses down the axons to the posterior pituitary, where these hormones are stored and released. Preoptic nucleus. Preoptic nucleus is responsible for thermoregulation. Okay, so there was a mnemonic for ADH and oxytocin, that is called as SAD POX. It is SAD POX. So suprachiasmatic nucleus is responsible for production of ADH, and paraventricular nucleus is producing oxytocin. So you may remember it like that. It is also written in the first year 2022. You may also see it from there, SAD POX. The preoptic nucleus, that is responsible for thermoregulation, sexual behavior, release of GnRH. Failure of GnRH producing neurons to migrate from the olfactory pit will lead to a Kallmann syndrome. Kallmann syndrome is a condition in which, if I am talking about a female, so there will be primary amenorrhea with anosmia, and if I am talking about a man, so there will be infertility associated with anosmia. Then the next thing is about hypothalamic nucleus. So there is a mnemonic for that. You can see this picture first. So functions of hypothalamus. Anteriorly, you can see this. Suppose this car is hypothalamus. So anteriorly, there is the bonnet of the car. So anteriorly is radiator. So you know that in the engine of the car there is a thing that we call the radiator. We put water inside that. So the radiator's function is to cool the engine. So since the radiator is located anteriorly, so you may remember it like that, that anteriorly we have heat dissipation center, or anteriorly there is a cooler. Then laterally is the gas cap. So when the cars are hungry, we open this gas cap and we put the gas inside that, or we put the petrol inside that. So laterally is the gas cap, that is for the hunger centers. Medially is the gas tank, that is satiety. So the tank is medially, while the mouth of the gas or the gas tank is laterally. So just a mnemonic, you may see it like that. It is useful by the way. Posteriorly is the exhaust, that is heating. So we cool the engine by radiator. So it means that engine has a cooling center, and posteriorly we have the exhaust, which are dissipating the heat outside, which are so posteriorly we have the heating center. Then we have sunroof, that is suprachiasmatic. When you see the stars, you want to go to sleep. So circadian rhythm is controlled by the suprachiasmatic nucleus. Next we have hypothalamic syndrome. Just like thalamic syndrome, now we have hypothalamic syndrome. If there is damage to the hypothalamus, there will be diabetes insipidus due to loss of ADH. There will be fatigue, loss of CRH, and because of corticotropin releasing hormone is not there, there will be low cortisol. Then there will be obesity, and loss of temperature regulation will also be seen. Limbic system. Limbic system is basically the collection of the neural structures involved in emotion, long-term memory, olfaction, behavioral modulation, and ANS function. It consists of hippocampus, which is shown by the red arrow. Okay, so this is hippocampus, this one over here, amygdala, mammillary bodies, anterior thalamic nuclei, cingulate gyrus, that is yellow arrows in the A, so these are the anterior cingulate gyri. Then we have the entorhinal cortex as well. So these are the constituents of the limbic system, but you need to remember about hippocampus, which is for the short term memories, amygdala for the sexual urges, mammillary bodies, which are very important when we will talk about the Wernicke-Korsakoff syndrome, the one in which we have thiamine deficiency in the alcoholics. So there is degeneration of the mammillary bodies in those people, and yeah, these three structures are very important. So limbic system is responsible for feeding, fleeing, fighting, feeling, and sex. You may remember it like this. Okay, so if you are like this is 1 2 3 1 2 3 4, and fifth F is about this thing. I'm sorry for the words, but it is easy to remember like that. So it's like feeding, fleeing, fighting, feeling, and sex. So the next thing is about the limbic system. The limbic system is depicted in this picture. So here you can see this is the purple thing is hippocampus. Then we have the parahippocampal gyrus, the cingulate gyrus. These are the components in the cerebrum. Then there is the pineal gland, the fornix is over there, the corpus callosum. The components of the diencephalon include anterior group of thalamic nuclei, hypothalamus, and mammillary bodies. And there is a amygdaloid body as well. You don't need to remember this picture. It is not very high yield. This picture is important. Moving forward to this point, this is I guess a picture from Snell's neuroanatomy. I'm not sure, but let's talk about it in an anti-clockwise fashion. So this is corpus callosum. Corpus callosum is a connection between the two hemispheres. It is a tuft of neurons which is connecting the two cerebral hemispheres with each other. Then we have septum pellucidum. Then there is a thing that we call fornix. Then anterior commissure is over there. Then we have the this is anterior commissure. Then we have hypothalamus, like this thing. After that we have the mammillary body. This is the protrusion over here. Then there is the midbrain, the pons medulla, which is constituting the brainstem. Then behind that we have cerebellum, the fourth ventricle, the cerebral aqueduct is over there. The calcarine sulcus, which is the visual areas over there. Pineal gland, parieto-occipital sulcus. I'm sorry. The parieto-occipital sulcus is like over here, like this is the parietal lobe, and this is the occipital lobe. So between them we have a sulcus that is called as the parieto-occipital sulcus. Then here is the thalamus, and then choroid plexus. Moving forward to this picture, they sometimes give you a diagram like that. So the picture number A is depicting fornix, like this is the arrow is indicating this structure, that is fornix. Then we have the arrow B that is depicting the mammillary body. The C is depicting pons, the D is depicting the thalamus, E is depicting the inferior colliculus, and F is depicting I guess the corpus callosum. I'm not sure about that. Next point is about the Wernicke-Korsakoff syndrome. Wernicke syndrome is associated with acute encephalopathy, and Korsakoff syndrome is associated with a chronic neurological condition. Usually it is a consequence of Wernicke, so that is why we call it a Wernicke-Korsakoff syndrome, because initially we have acute encephalopathy, and if it becomes chronic, then that is called as the Korsakoff syndrome. Both are associated with the thiamine vitamin B1 deficiencies from alcoholism. Remember that alcoholics, they are malnourished people, and because they don't take enough diet and they vomit a lot, so that is why they are malnourished, and those malnourished people have deficiency of a lot of vitamins. The macroscopic picture will be atrophy of the mammillary bodies. Emotional and memory are common findings. So there will be emotional loss and memory loss will be there. It is associated with the damage to the thalamic nuclei, anterior and dorsomedial. The Wernicke triad consists of confusion. The person will not be oriented to person, place or time with a variable degree. There will be gait ataxia, and visual disturbances or nystagmus will be there. It is often reversible with thiamine. Korsakoff syndrome is associated with amnesia, recent memory affected more than remote memory, can't form new memories, confabulations, can't remember, so make things up. It is like since the person is having a memory issue, so he does not remember what he has taken in the breakfast. So when the patient is being asked that what he or she has taken in the breakfast, or maybe how has she come to the hospital and who has brought her to hospital, so they start making things up. They are innocent lies, and that they are called as confabulations, and those are associated with the Korsakoff syndrome. So remember, the Korsakoff is associated with amnesia. I'm sorry. While the Wernicke is associated with the confusion, gait, ataxia, and nystagmus. Then the lack of interest or concern will be there, personality changes will be there, and the Korsakoff syndrome is usually permanent condition, because you know that Korsakoff syndrome is a chronic condition, and this chronic condition is usually permanent. Wernicke encephalopathy, Wernicke precipitated by glucose without thiamine. It is a very important scenario, and you must remember it. Thiamine cofactor, glucose metabolism, pyruvate dehydrogenase enzyme. Alcoholic or malnourished patients should receive intravenous thiamine supplementation before intravenous dextrose administration, because giving dextrose without prior thiamine can precipitate a Wernicke encephalopathy, because vitamin B1 or thiamine is a cofactor to a lot of enzymes which are responsible in the carbohydrate metabolism, including the pyruvate dehydrogenase enzyme. So alcoholics, they are already deficient in vitamin B1. On top of that, if they come to your emergency and you give them dextrose alone, the remaining stores of the vitamin B1 which are present in their body will be used to metabolize the administered dextrose, and there will be further deficiency of vitamin B1 and person will develop Wernicke-Korsakoff syndrome. Now these pathways are very important. So dopaminergic pathways, commonly altered by the drugs, for example antipsychotics, and movement disorders, for example Parkinson's disease. So commonly altered by the drugs, for example antipsychotics and the movement disorders like the Parkinson's disease. There are four important dopaminergic pathways: mesocortical, mesolimbic, nigrostriatal, and tuberoinfundibular pathways. So the first pathway is the mesocortical pathway. The mesocortical pathway symptoms of altered activity. So if the mesocortical pathway, the mesocortical pathway, if it is affected, so there will be decreased activity, negative symptoms like anergia, apathy, lack of spontaneity. They will be seen if the mesocortical pathway is inhibited or affected. Notes: antipsychotic drugs have limited effect on the mesocortical pathway. No. Antipsychotic effect have limited. I don't know about this one. Symptoms of altered activity and antipsychotic drugs. Okay, so I think that if the mesocortical pathway is damaged, antipsychotic effects have limited activity against that. It cannot cure the damage to the mesocortical pathways. Then there is mesolimbic pathway. In this we have increased activity. The positive symptoms will be there, for example delusions or hallucinations. Primary therapeutic target for the antipsychotic drugs. Antipsychotic drugs are responsible for decreasing the positive symptoms, for example in schizophrenia. Then we have nigrostriatal pathway. If the nigrostriatal pathway is damaged, there will be decreased activity. Extrapyramidal symptoms like dystonia, akathisia, Parkinsonism, and tardive dyskinesia will be seen. Major dopaminergic pathway in the brain significantly affected by the movement disorders and antipsychotic drugs. Tuberoinfundibular pathway. If the tuberoinfundibular pathway is damaged, there will be decreased activity, increased prolactin, and decreased libido, sexual dysfunction, galactorrhea, and gynecomastia in men. So these are the pathways. Initially, the pathway number A, that is over here. It is a nigrostriatal pathway which controls the movements. It is from the substantia nigra to the striatum, so it controls the movement. The second pathway is mesolimbic pathway, which is depicted by the picture B. It controls the reward and perception. So it is coming from the, you can see that meso is for the midbrain and limbic is for the limbic system. So it is coming from the midbrain all the way to the nucleus accumbens. So it is a mesolimbic pathway. After that we have mesocortical pathway. It controls the executive function. So it is from the midbrain to the cortex, as you can see in this Charlie. So it is originating in the midbrain and going all the way to the cortex over here and over here. The next thing is about the tuberoinfundibular pathway. It controls the pituitary prolactin function. So pituitary prolactin function, how? Because the tuberoinfundibular pathway, as you can see in this picture, that it is deep. So it is a tuberoinfundibular pathway. So it is responsible for the secretion of dopamine. Dopamine is an inhibitory hormone that is produced from the tuberoinfundibular pathway, and that exerts its effect on the lectrotroph cells of the anterior pituitary, which are responsible for the prolactin secretion. If the dopamine is not there, so the prolactin secretion, like the prolactin, will be increased. And prolactin, if the level of prolactin increase, that will lead to galactorrhea and gynecomastia and decreased sexual urges and stuff like that. So you must remember it like that. Next point is about the cerebellum. So cerebellum is like this. You may divide the cerebellum into central and peripheral parts. This division is very important. We'll see that in a minute. So basically the anatomical distribution of the cerebellum is into central vermis and peripheral hemispheres. Then talking about the lobes of the cerebellum, the first thing, they are most anterior, the anterior lobe, then we have the posterior lobe. After that we have folliculus, and there is folliculonodular lobe, and this is nodulus. Now if we see the CT scan, so this structure, this triangular structure, this is called as the cerebellum, this thing, yeah. So this is the cerebellum of this person. Now as per cerebellum, the very first thing that you need to remember is all the lesions of the cerebellum will cause ipsilateral effects. Now let's talk about functions. of cerebellum is responsible for posture and balance, for maintaining the muscle tone, and for coordination of the movements. Cerebellar peduncles, in and out pathway. So middle and inferior cerebellar peduncles take the messages from the body to the cerebellum, while the superior cerebellar peduncle take the messages from the cerebellum to the cortex. So middle and inferior peduncles are bringing the message to the cerebellum, and superior cerebellar peduncle is taking the message away from the cerebellum. Now here you can see, this is a complex picture, but you can see this one. So let me show you that this is the inferior cerebellar peduncle, this is the middle cerebellar peduncle, and this one is the superior cerebellar peduncle. If you could follow the arrows only, so you can see that messages are coming into the cerebellum through the inferior and the middle cerebellar peduncle, while the messages are coming out of the cerebellum by the superior cerebellar peduncle. Now let's see them one by one. Yes. Now here you can see that the climbing fibers from the inferior olive, the proprioceptive information from the spinal cerebellar tract, which are mossy fibers, they enter the inferior cerebellar peduncle. The pontine mossy fibers enter through the middle cerebellar peduncle. Both of these fibers will end up on the deep cerebellar nuclei, which are dentate nucleus, interposed nucleus, and the fastigial nucleus. Now these nuclei will send the signals towards the brain, to the thalamus and red nucleus by superior cerebellar peduncle, right? And then we have the corticopontine fibers, which are coming from the cortex to the pons. Like these fibers are coming from the cortex all the way down to the pons, and from the pons the messages are going to the cerebellum. So this is how the things are working. Now this type of cell is called the Purkinje cell. We'll talk about that in just a while. So inferior cerebellar peduncle. Inferior cerebellar peduncle is the major pathway into the cerebellum from the spine. There are numerous inputs, like there will be spinocerebellar tract, cuneo-cerebellar tract, olivocerebellar tract, and vestibulocerebellar tract. Ipsilateral spinal cord information, that is proprioception from the spinal cord, is taken up by the spinocerebellar tract to the cerebellum via the inferior cerebellar peduncle. Then the second peduncle is the middle cerebellar peduncle. They take the fibers which are pontocerebellar fibers, and fibers from the contralateral pons are entering the cerebellar peduncle. The next thing is about the superior cerebellar peduncle. So the major pathway out of cerebellum, superior cerebellar peduncle is a major pathway out of the cerebellum. Axons from the deep cerebellar nuclei are entering into the superior cerebellar peduncle to go towards the cortex. All outputs originate from the deep nuclei. Fibers to the red nucleus and thalamus to modulate the cortical movements. What are Purkinje cells? Purkinje cells are the cerebellar neurons. They receive numerous inputs and they project to the deep nuclei, and Purkinje cells are always inhibitory, they release the GABA. The next thing is about the deep nucleus. So firstly, to remember the names of the deep nucleus, you must remember the mnemonic: don't eat greasy foods, which means dentate, emboliform, globose, and the fastigial nucleus. And this is if we move from lateral to the medial direction. And now you can see that this is the lateral, this is lateral and this is medial if we move from lateral to medial direction. So firstly we will encounter the dentate nucleus, then we have the emboliform, the globose, and then the fastigial nucleus. Projections out of the cerebellum are so these deep nuclei will have their projection going out of the cerebellum. The next point to remember is about the individual nuclei. So dentate nucleus is the most important and most lateral nucleus of the cerebellum. It is the most important and most lateral nucleus. It projects to the contralateral Ventro-anterior and ventrolateral nucleus of the thalamus to modify the movements, the same projection as the basal ganglia. So the anterior nucleus has same projections as the basal ganglia. Interposed nucleus, which is also called as a globose or emboliform nucleus. So interposed nuclei are two, which are globose and emboliform nuclei. They end up on the contralateral red nucleus and the vestigial nuclei to the vestibular nuclei of the reticular formation. So when I said that most of the pathways and most of the lesions and their symptoms of the cerebellum are ipsilateral, so this is the most common finding for the cerebellum. But there are some areas where we find contralateral, contralateral orientation, like for the pontocerebellar fibers, they are coming from the contralateral cortex, or if I talk about the red nucleus, the output of the interposed nucleus to the red nucleus is also contralateral. So you must remember these small points, but as a general rule of thumb, you may remember that the lesions of the cerebellum will cause ipsilateral effects. Then we have cerebellum input, contralateral cortex via middle cerebellar peduncle, ipsilateral proprioceptive information via inferior cerebellar peduncle from the spinal cord. Cerebellum output. The only output of the cerebellar cortex is Purkinje cells, which are always inhibitory. They go to the deep nuclei of the cerebellum, and from there they go to the contralateral cortex via superior cerebellar peduncle. Okay. So the next thing is about. So you may think of it like that. I'm sorry. If I draw it over here, suppose this is cerebellum, and this is cerebellum, something like this, and this is the cortex, like this. Suppose this is left side, this is the right side, and this is left side, and this is the right side and left side. If I'm talking about the output of the cerebellum, this is coming from the right side, this is coming from the right side to the left side of the cortex, right? This is the output of cerebellum, and then from the cortex the information will go down, and then it will decassate and go to the right side. So the final output is going to the right side ultimately. As you can see, that is cerebellar input that originated in the right side went to the left cortex, and from the left cortex it went downwards down the spinal cord and came back to the right side. So that is the reason all the lesions of the cerebellum cause ipsilateral effects. I hope that I could clear the concept. Now let's move forward. The cerebellum control. In general, the cerebellum controls ipsilateral side. In general, cerebellar fibers go to the contralateral cortex. The contralateral cortex will go to the contralateral arms, right? So that crosses twice. So suppose I'm talking about right to left. So fibers from the right cerebellum go to the left cortex. The contralateral cortex, that is, the right cerebellar fibers go to the left contralateral. The right cerebellar fibers go to the left cortex. From the left cortex supplies the right arm or leg. So now you can see that we started on the right side and we ended up also on the right side. That is why cerebellum can control the ipsilateral side of the body, because there is twice, the fibers are crossing twice. Also, right proprioception will lead to right cerebellum. Results are left cerebellar lesions will lead to left symptoms, and right cerebellar lesions will lead to right symptoms. Then moving forward, we have cerebellum lesions. If there are lateral lesions, I hope there is homunculus. So in this homunculus you can see that the axial part of the body, which includes the head, the neck, the abdomen, the pelvis, they are controlled by the vermis, while the appendages, which are the lateral part of your body, which are the legs and the arms, they are controlled by the lateral hemispheres of the body. So you must remember it like that. Okay, so now here you can see that if there is medial line lesions which are to the vermis, for example to the emboliform globose and vestigial nucleus and to the folliculonodular lobe, they will affect the trunk, and there will be truncal ataxia, that is, there will be wide based gait. They can't stand independently, falls over when sitting, and lesion in the vermis. Nystagmus and vertigo will be present, lesion in the folliculonodular lobe. If I am talking about the lateral lesions, they are lesions to the cerebellar hemisphere and the dentate nucleus. They affect the extremities. The person will fall towards the ipsilateral side of the lesion, or maybe to the ipsilateral side of the lesion. There will be dysmetria, and intention tremor. Romberg test of the sensory, not the cerebellar ataxia. Romberg test is a test for sensory, not cerebellar ataxia. There will be loss of proprioception, and the people will be compensating through vision. And remember, we are not talking about cerebellar lesions here. The Romberg test is not positive for cerebellar lesion. It is a test for the sensory ataxia. For example, if there is some lesion to the dorsal spinal cerebellar tract in the spinal cord, then the Romberg sign will be positive. It is not positive in cerebellar lesions. But we need to learn about that. So test for sensory, not cerebellar ataxia. Loss of proprioception compensate through vision. How do we perform the test? The patient is asked to stand with his feet together and eyes closed. If the Romberg test is positive, patient will lose the balance or fall as soon as the eyes are closed. If test is positive, ataxia is sensory. Cerebellar ataxia occurs even with the eyes open. So closing the eyes does not exaggerate or cause the loss of balance in the cerebellar ataxia. In the cerebellar lesion, so cerebellar ataxia occurs even with the eyes open. Functional anatomy of the cerebellum. Now here you can see that the vermis, which is this green structure, it is medial descending system, and intermediate hemisphere it is a lateral descending systems, and they are responsible for motor execution. The lateral hemisphere, they send the symptoms, they send the fiber to the motor and premotor cortices for the motor planning, and follicular nodular lobe goes to the vestibular nuclei for the balance and eye movements and stuff like that. So you must remember, this is a picture from the Uworld and it is a good one. So here you can see that the spinal cerebellum is taking control of the axial skeleton. Don't get confused by these appendages, because here they are telling you about the proximal muscles like the shoulder muscles and the pelvic girdle muscles. Then there is not just the folliculus and the spino and the cerebellum and stuff like that. Now let's move forward to the other cerebellar part symptoms. So other cerebellar symptoms, whenever there is lesion to the cerebellum, definitely there will be ataxia. There will be, yes, there will be ataxia. But the other symptoms include hypotonia, because we have seen that it controls the tone. So loss of muscle resistance to the passive manipulation, and loose jointed floppy joints will be there. There will be scanning speech. Spoken words are broken into separate syllables, often separated by a noticeable pause and spoken with varying force. How are you doing will be how are you doing. So it is scanning speech. It is a typical symptom of multiple sclerosis. An important thing to be remembered, that scanning speech is because of the cerebellar lesion and is an important component of the multiple sclerosis. Then we have dyssynergia, loss of coordinated activity. Dysmetria, loss of movement coordination under or overshoot intended position of the hand. That is called as dysmetria. Then we have intention tremor, can't get the hand to the target. Contrast the resting tremor, contrast it with the resting tremor, that is the Parkinson's. Dysdiadochokinesia, can't make movements exhibiting a rapid change of motion, can't flip hand in palms. So you may see the video of dysdiadochokinesia. The person is asked to flip one hand on the palm of the other rapidly, and the person who has dysdiadochokinesia cannot do that. Nystagmus is up down beat, vertical nystagmus, and gaze evoked nystagmus can be seen. So this is an important thing, that central nystagmus is mostly vertical. So there will be up down nystagmus, while the peripheral nystagmus, that is caused due to the damage to some cranial nerve like cranial nerve 6 or maybe cranial nerve 3, that is mostly horizontal. Then nausea and vomiting is associated with the cerebellar lesions, and vertigo is also, central vertigo is associated with the cerebellar lesions. Now let's talk about cerebellar strokes. Affect any of the blood supply. So cerebellar strokes cerebellar strokes can affect any of the blood supply to the cerebellum, that is superior cerebellar artery, ICA, that is anterior inferior cerebellar artery, and PICA, that is posterior inferior cerebellar artery. Often has other brainstem stroke signs and symptoms as well. Hereditary ataxia, motor incoordination related to cerebellum, ataxia telangiectasias and Friedreich ataxia. So these are hereditary ataxias, which are ataxia telangiectasia and Friedreich ataxia, and they are motor incoordinations related to the cerebellum. What is ataxia telangiectasia? Ataxia telangiectasia refers to the autosomal recessive cerebellar atrophy. Ataxia in first year of life will be there. Telangiectasias, which are dilation of the capillary vessels on the skin, ears, nose, face and neck, and along with that, ataxia telangiectasia has a triad. First one is ataxia, second is telangiectasia, and thirdly we have severe immunodeficiency, that is IgA deficiency. Repeated sinus and respiratory infections will be there. there is high risk of cancer. The cause is DNA hypersensitivity to ionizing radiation. Why is that happening? Because there is defective ataxia telangiectasia mutated gene, ATM gene, on chromosome number 11. Functions of ATM gene is repairs the double-stranded DNA breaks. Non-homologous end joining will not occur because of deficiency of the ATM gene. Mutation of the ataxia telangiectasia mutated or ATM gene will lead to failure of repair of the DNA mutations. Lab abnormalities in the ataxia telangiectasia will lead to increased alpha fetoprotein, often elevated in the pregnant women, also elevated in ataxia telangiectasia's most consistent lab finding. Second thing is dysgammaglobulinemia, which means there will be low or absent IgA. Now the other form of hereditary ataxia is Friedreich's ataxia. So firstly you should see that the areas of the spinal cord that are involved in the Friedreich ataxia are the dorsal columns, which are responsible for the vibration and proprioception sensation, the dorsal root ganglia, which are responsible for all kind of sensations to enter the spinal cord, then the spinocerebellar tracts, which result in the ataxia. Now let's talk about that. The dorsal columns and the dorsal root ganglion, if these are damaged, there will be loss of proprioception and vibration sensation. If the spinocerebellar tracts are lost, there will be ataxia. If the lateral corticospinal tracts are damaged, so there will be spastic paralysis, because the lateral corticospinal tracts contain upper motor neurons, and if the upper motor neurons are severed, we know that there is spastic paralysis. Along with that, Friedreich ataxia is associated with a hypertrophic cardiomyopathy and kyphoscoliosis. Now you can see in this picture that there is kyphoscoliosis like this. So autosomal recessive condition, ataxia telangiectasia was also autosomal recessive, right? Most of the conditions, like it is a rule of thumb that most of the conditions are autosomal recessive. If you find any condition that is autosomal dominant, you must remember that, because there are very few autosomal dominant conditions, rest of them are autosomal recessive. Then we have Friedreich ataxia. Mutation of the frataxin gene on the chromosome number 9. It is needed for the normal mitochondrial function. Increased number of the trinucleotide, that is GAA repeats pattern. More repeats will lead to a worse prognosis. It leads to decreased frataxin levels. Frataxin is the mitochondrial protein that is an iron binding protein. As the name indicates, frataxin, it is something like iron Fe. So frataxin, iron binding protein, high levels in the brain, heart and pancreas. So this is the reason that in Friedreich ataxia we are having symptoms in the brain like ataxia due to the cerebellar injury. That is not exactly because of cerebellar injury, that is because of the injury to the spinocerebellar tracts, but ataxia is there. Heart, there is dilated cardiomyopathy, and pancreas. Most of the patients with the Friedreich ataxia also have diabetes mellitus. Abnormal frataxin lead to abnormal mitochondrial function or mitochondrial dysfunction. Cerebellar and spinal cord degeneration. Degeneration of the spinocerebellar tract will lead to ataxia and staggering gait. Dysarthria that is caused by that. Loss of dorsal column will lead to loss of position and vibration. Loss of corticospinal tract will lead to spastic paralysis in the lower extremities. Loss of dorsal root ganglion will lead to loss of deep tendon reflexes. Other features include hypertrophic cardiomyopathy, that is the cause of death, diabetes, that is insulin resistance and impaired insulin release. Beta cell dysfunction will also be present. The next thing is about kyphoscoliosis. Foot abnormalities, that is pes cavus. Pes cavus mean high arch of foot and does not flatten with the weight bearing. Seen in other neuromuscular diseases as well, like Charcot-Marie-Tooth disease. So the constellation of symptoms in the Friedreich ataxia includes staggering gait, frequent falling, nystagmus, that is up down nystagmus, central nystagmus, dysarthria, pes cavus, hammer toes, diabetes mellitus, hypertrophic cardiomyopathy, that is most commonly cause of death. So the mnemonic is Friedreich is frataxic, that is frataxin. He is your favorite frat brother, always staggering and falling, but has a sweet big heart, and ataxic GAAIT. So you may remember that there is GAA trinucleotide repeat expansion in the Friedreich ataxia. Then there is paraneoplastic cerebellar degeneration. Paraneoplastic means that it is a side effect of some neoplasia, some cancer, and that is cerebellar degeneration. So small cell lung cancer is very important in that. So let's talk about that. Autoimmune phenomena result from it is an autoimmune phenomena result from the immune reactions against the tumor cells that cross react with the normal cell, for example the Purkinje cells of the cerebellum, Acute onset rapid degeneration of the cerebellum, most commonly associated with small cell lung cancer as well as breast, ovarian, and uterine malignancies. Anti-Jo, anti-P by Q, and anti-HU are most common antibodies detected in the serum. Next we have the basal ganglia. Now this is very important and high yield. It is very simple as well. It is not that complex. It is not difficult at all. Structures of the basal ganglia include substantia nigra that is present in the midbrain. Then we have the subthalamic nucleus, the putamen, caudate nucleus, and globus pallidus. All of these are subcortical structures. Then we have this picture which is depicting all of them. So the most prominent highlight in this lateral view is this C-shaped nucleus, which is the caudate nucleus. Now if I show you the cut section, anatomy of the basal ganglia, so the caudate nucleus, the purple nucleus, so if it is suppose this is like a C-shaped structure in a 3 dimension, if I do a cut section, so only the head and the body will be visible. Like the caudate nucleus, the body is over here, and this is also caudate nucleus, remnant of that, not a remnant but cut section of that. So this is the caudate nucleus. Then we have the internal capsule. This green thing is a thalamus. Then we have the lentiform nucleus. Lentiform nucleus is subdivided into putamen and globus pallidus. Then subthalamic nucleus is the green one. This is subthalamic nucleus. Then we have the substantia nigra, that is the dark area in the midbrain, and that's it. So let's talk about the basic terminologies. So the striatum, when we talk about striatum means putamen plus caudate nucleus. So putamen and caudate nucleus together is called as striatum. So putamen is motor and caudate nucleus is for the cognition, also called as striate nucleus. Putamen caudate divided by internal capsule. It is a major input from the cortex. Lentiform nucleus is the putamen plus globus pallidus. If putamen and globus pallidus are thought of to be together, so that is called as the lentiform nucleus, while striatum is only putamen. So let's talk about this. This is a lens shaped nucleus, this one. If I could change the color so that you can see it more clearly. So like this. Yeah. So this area, this thing. Okay, I'm sorry, that's my bad. That's not even visible now. Pencil is good. So this area, that the lens shaped nucleus is called the lentiform nucleus. As you can see here, that this lentiform nucleus consists of two things, that is the outer putamen and the inner globus pallidus, right? So globus pallidus and putamen together form this lens shaped nucleus that is called as the lentiform nucleus. If I think of caudate nucleus and putamen together, that is called as striatum. So caudate nucleus and putamen together are striatum, while the putamen plus globus pallidus, that is called as lentiform nucleus. And between the caudate nucleus and the putamen we have this internal capsule. The next thing is about the Wilson's disease. Wilson's disease causes cystic degeneration of the putamen as well as damage to other basal ganglia structures. So Wilson's disease is specifically associated with the damage to the putamen. Wilson's disease is a copper accumulation disease. The next thing is again about the structures, these basal ganglioid structures. So in this picture you can see we'll go in anti-clockwise direction. So there is a lateral ventricle, we have discussed that in detail. Then we have caudate nucleus, then the internal capsule is over there, after which we have putamen and globus pallidus, externa and interna together, they are called as lentiform nucleus. If the putamen and caudate nucleus are thought of together, so they are called as striatum. Then we have this yellow structure, that is the thalamus. The subthalamic nucleus is just below the thalamus, and then we have the substantia nigra. After this we can see this CT scan, and now here you can see the caudate nucleus. This frosy or teal color structure is the caudate nucleus. This highlighted area is the lentiform nucleus, and behind that is green structure is the thalamus. Now here you can see that the caudate nucleus is the anterior green area, that is the head of the caudate nucleus. Then we have the putamen. The internal capsule is between the putamen and thalamus, and between the putamen and caudate nucleus as well. Then here you can see the lateral ventricles, these small blue structures like over here, these things, lateral ventricles, anterior horns. Then we have the pineal gland, the lateral ventricle posterior horns, and then we have the hippocampus that is present over here. After that, the function of the basal ganglia. The basic general function of basal ganglia is that they modify the voluntary movements and make the postural adjustments. They receive the cortex input. They provide the feedback to the cortex to either stimulate the motor activity or inhibit the motor activity. The combination of stimulation and inhibition leads to a complex movement. So basal ganglia are basically the modulators of the movement. Like they control the movements which are basically originating in the premotor cortex. So suppose that you want to take a cup of tea, right? So if I draw a brain over here, like a very bad diagram of the brain, but this is a central sulcus. Here we have the primary motor cortex, and just anterior to the primary motor cortex there is the premotor cortex, right? So you planned to take a cup of tea in the premotor cortex, okay, premotor cortex. Then the message went to the, from the premotor cortex the message will go to the basal ganglia which are present over here. From the basal ganglia the information will go to the thalamus, and from thalamus back to the primary motor cortex, and from the primary motor cortex information will go down. So the modulation, the control of the movement which is being planned in your brain, which you are thinking about, that is or maybe which you are not voluntarily thinking about but is there in your brain, that is coordinated or modulated, controlled by the basal ganglia. Now the basal ganglia can perform both functions. They can either stimulate the motor activity or they can also decrease or inhibit the motor activity. Both functions can be done by either direct or indirect pathway respectively. We'll see that one by one. So movement execution. Premotor cortex decides to execute the movement. Then it sends signal to the basal ganglia. Basal ganglia via direct pathway will activate the primary motor cortex, or maybe via indirect pathway it inhibits the primary motor cortex, and then the primary motor cortex will perform the complex movement or action. Firstly, we will talk about the direct pathway. Before confusing ourselves on the direct pathway, let's see the picture of direct pathway. So this is the direct pathway, the normal basal ganglia motor pathways. So in the direct pathway, the motor cortex, that is the premotor cortex, that gives excitatory signals to the striatum. You know what is striatum? Striatum is caudate nucleus plus putamen, right? So striatum in direct pathway will give inhibitory signals to the globus pallidus internus, substantia nigra pars reticula. Okay. Then globus pallidus internus will send inhibitory nucleus to the thalamus, and that thalamus will be excited. Okay, I'm sorry, I just confused you on all of this. So I guess this diagram is better, or this is actually a long concept, so we will continue with this thing in the next section. So until then we'll keep it here, direct pathway, about direct pathway, and then from the explanation of direct and indirect pathway we'll continue in the next session. Until then, Allah Hafiz, fi amanillah, and take care.